We focus largely on thinking about how health programs can integrate digital and digitally enabled AI services as part of preventive and curative services, mostly in low and middle income countries. Uh, Natisha provided us with brief introductions to the panelists, and I'll introduce their work a little bit more, and we'll hear from them. But I think as we are talking about in our panel today, and I know we've had some other panels on digital and AI, what we'll focus on is understanding from three very different perspectives, because we have Shibu here, who's really focused on TB diagnostic technologies and Qure AI. So very sort of grounded in implementation focus. And then we have Dr. Chellappa here, who is focused and who's really, before AI became sort of the buzz of the town, he's been working in the data science and AI space for 4 decades, I was told. And then Marelize Gorgens, who's really bringing a very a broad and comprehensive lens from working very closely with LMIC country governments and bringing that context and the voice of what the World Bank perspective from hearing from those governments are. So very different perspectives, and we'll hear more from the panelists today. Maybe I can dive right into the questions. And Shibu, maybe I'll start first with you. So you work with Qure. Are you checking your mic? Okay. But you work with Qure AI on TB diagnostics, and I think there is, of course, Qure AI is using AI, as the name suggests. But I would love to talk from you about. You can talk a little bit about the product, but really talk about what has been your experience in placing the product in practice, right? Like, what have been some of your observations and learnings in ensuring that there is uptake, that it integrates with clinical workflow, and that it actually has an impact on health outcomes?
That is a great question, actually. So, I mean, our CEO always mention that algorithm is just 20% of it. The rest of it is all integration, creating workflow, and then closing that loop. How do you position your tool in the health system? So just to explain what our product is a radiology image interpretation software, which is AI-driven just X-ray interpretation. It actually interprets full X-ray and provide an automated report and calls out specific diseases. Tuberculosis has been one of them. It calls out pneumonia, TB, pleural effusion, lung nodule characterizes, and also characterizes lung nodule for lung nodule malignancy and give a score. So multiple use cases within one image and one investment. So I just want to explain that if you think about health system, you need to unlock this piece in the context of like getting the money is getting shrinking. So how do you leverage the technology to full extent? So come back to the TB, tuberculosis. TB, I mean, we heard from the previous sessions, like the importance of chest X-ray in diagnosing or in tuberculosis. So, I mean, in my childhood, primarily X-ray was the mainstay of it because the mass miniature radiography was the cornerstone of tuberculosis detection in high-burden countries, wherein vans go and take X-rays. And it's a stamp-size X-ray. It's like a passport-size photograph X-rays. Doctors used to actually view that and then report it. So that was the TB mainstay diagnosis. Fortunately, later, then the science improved, and then we started diagnosing with microbiological diagnosis, which is a gold standard of any infectious disease diagnosis. You need to see the bug or grow the bug or extract the bug elements like molecular testing. So, but now it's a bellwether coming back for a T. I mean, in the fashion industry, the bellwether coming back. X-ray for TB industry is X-ray coming back. Essentially, because if you are not using a sensitive tool, half of your patients are asymptomatic. So you have to have a sensitive tool like an X-ray to come back. Then on the same side, the engineering efforts to downsize the larger machines into smaller, tinier versions of X-ray machines happen. And you can now, so the access and mobility aspects of the heavy machines has been addressed. Now we can go to the population, screen them. So you identify the vulnerable population, started screening them. who is going to read the exercise. So there comes the value of AI. I just want to position that why AI? Why not doctors, right? Okay, there is a dearth in this thing, and dearth is more relevant than where the vulnerable are there. So that is where the AI coming. So the first algorithm, so I have two life cycle within my AI acquaintance, like when I was with Path, when I was testing this algorithm as a science innovation accelerator and first adopter of Qure AI in the TV space. So in that, when we deployed that in one of the sites in Nagpur in Maharashtra, the first thing was just like, there's no internet. So the public, so weird, how do you solve it? Like, so the public system said there is internet. So starting from that, actually making the modality software, that is X-ray modality software, talking to AI software, which is actually an engineering effort. So integrating that with this and it's wiring, it's just wiring. And enabling that, okay, this, you can't do it on a private X-ray system. So they will say, oh, we don't allow. So you have to have a separate laptop for it. So starting from that, we learn what are the hardware requirement to get it integrated. So then comes, okay, government don't want actually things go to the cloud. So then how do you make it actually on-premise? So you have to come up with another innovation, which is called a Q box. You kind of compress all your, algorithm into a small box. And then our engineers came up with a collaboration with Intel and come up with Q box. It's a small box where your algorithm sits. It can go online when it has decided. So I think the learning is hardware, software, and again, then so you started diagnosing or identifying more probability because do you have the wherewithal to test it, right? You don't have logistics of gene expert or molecular test available in your facilities. So you make the system prepare, hey guys, you are going to see more probable cases, you need more logistics around it. You have to have linkages to prevent patient leakages. Like, so I came to the facility for some other thing. Doctor asked me to take an X-ray. I'm not coughing, but I am identified as a presumptive TB case. I need to ask to deposit my sputum, right? So I need to get convinced by somebody to link me to the lab. So we found leakages of around 60% in the initial stages. So we have to work with the government to make that to 80 to 90%, make the patient. So I think creating, so this was manual initially, then we created something called Qure, which actually digitized the patient movement, right? Starting from I'm getting registered, I'm getting identified by X as a probable case, I'm getting diagnosed and linked to the gene expert or sputum result, then I get initiated on treatment. So you continuously, so this is visible to in an ecosystem of health workers, doctors within the facility, and make sure, and if I get if I'm dropping out of one place, there's a trigger, digital trigger coming to the health workers. Hey, this guy is not deposited the sputum. So Qure is a care coordination pathway. So we started with QXR, which is an AI software for X-ray interpretation, and Qure come later as a learning. I'm just talking there. There are a lot of more learning. I'll come back to that later.
Yeah, and that is such a good example of just you have this technology, but really to get it to work for healthcare, you're solving for one mobility, the hardware, right? You're solving for the software, you're solving for interoperability, data exchange, you're solving for clinical workflow. I think a really important point that you picked out, which I'm sure Marelize has much more to say on, is you're solving for how data will be hosted, and because that, as we know, is a big contentious issue. And with all of that, like the technology is really a small piece of the bigger puzzle. I would maybe come back to you to ask you, because I'm curious where you started, right? Like if you knew this in the front, or you as in Qure AI really knew it when you were approaching it, or were you like, hey, we've got this beautiful gadget and it's going to change lives, which is where I sit, the perspective that I often hear, right? Like we've got this brilliant algorithm or this beautiful gadget and it's going to change lives. But like, I think you really nicely emphasized the entire ecosystem, Marelize, which fits perfectly into, because you have, you launched the World Bank's seminal digital in AI, in health report. I'm not sure if I can call you the coiner of the term digital in health. You coined the term, and I would love for you to explain the concept of digital in health.
I think what Shibu explained actually is a good explanation of what we mean by this concept of not thinking about digital health, but thinking about digital in health. And what it really suggests is a move away from an individual siloed intervention or innovation-specific focus to more of an integrated ecosystem focus, whether that is the data ecosystem, whether that is the implementation ecosystem, whether that is the skills ecosystem, people needing digital skills. But it really suggests that when we think about digital technology, whether we're thinking about drug discovery, or we're thinking about training of health workers, or we're thinking about point of care diagnostic and screening solutions, we're thinking about logistics management, we're thinking about voice diagnostics for diabetes, which is another technology that is available, right? Regardless of which of these areas of healthcare we're referring to, if we think about WHO's 6 health building blocks, digital is really an increasing part of all of them, right? And I think that by using the term, the reason when we started with our flagship report, and we had many internal debates among the team, this concept of digital health, what bothered us about the term is that we speak about child health, maternal health, and digital health, right? And it creates yet one more silo, whereas what we're really talking about are the digital and AI-enabled components of health service delivery and of health systems management. So, in fact, I think I would posit that in a decade from now, maybe even in 5 years from now, we're not going to refer to digital health interventions. What we'll refer to are the digital and AI components of a health service. Your TB example is not a digital health intervention. There are digital and AI components, the X-ray, the AI, but it's still a radiologist that confirms. It's still a health worker that does a sputum test, right, or a lab technician. And so I think if we change our mindset from thinking about digital health interventions that often ends up being multiple apps on an Agarwal worker or a community health worker's phone, if we can think beyond that universe to have this integrated ecosystem approach where I ask, regardless of what area of the health system I'm working on or what health service I'm delivering, I can ask myself, what are the digital aspects of this and how does that feed into the health data ecosystem? How does that feed into the medical skills ecosystem and digital skills ecosystem that needs to be in place? So that's really the philosophy why we said about, we went from digitalization of health data to digital for health to digital in health. And that's really this integrated ecosystem way of thinking about not a digital health intervention as somehow a computer or a robot doing things by themselves, but it's really about digital augmenting what healthcare is delivered and how it is delivered and managed.
Thank you. That's super helpful. And I think since we're talking a lot about India here, one example we see is with ASHA workers in India who often have anywhere between 7 to 15 apps, right? One for nutrition, one for immunization, and increasingly there are more and more apps that they're expected to use. They have similar data components that they're capturing. Same patients, similar data components, and we're really sort of creating chaos in their lives while not solving for a problem of healthcare. So I think really a fundamental shift in how we think about digitizing, if at all, if it makes sense, the ecosystem to actually advance health outcomes.
Yeah.
You have.
No, I just wanted to absolutely agree with you. You know, we often even we have seen community health workers with multiple phones, right? With an app on every phone, right? And I think as long as we have this app silo-based approach, and yet we have the same patients, you have a pregnant woman who happened to have TB and is HIV positive and may develop gestational diabetes, right? She will be on 4 different apps. And her baby, when her baby is born, will be on yet another app, right? We are not we're not prioritizing the health of that woman. We're letting technology be the solution, and we need to focus on the problem. And that if we want to integrate healthcare and have a patient-centered approach, it starts with how we're thinking about the digital aspects of healthcare delivery and health systems management.
Yeah. Thank you. And I guess maybe another addition there is, of course, digital is the problem there, but it's also the vertical funding silos that really sort of precede the digitization, because part of why every vertical silo is getting digitized is because that's how we fund it. But but I think just sort of driving this, I think there's like a point that this panel can drive home is, I think, the concept of digital and health, which you very well articulated too, Shibu. So with that, moving on to you, Dr. Chellappa, is thinking about, because you've been, it's just a mic falling, everything is okay.
Drop the mic.
Okay, you've been engaged with a very sort of different types of variety of applications of digital and AI for several decades across Parkinson's and other conditions. And what has been your experience in translating academic, research-based, very rigorous models into practice? So continuing on the same theme of how do we actually ensure that what we as a university or as an academic group are working on has translatable impact on the community?
Thank you. Before we came here, we had a meeting in the other room. And it turned out we are going to be very friendly with each other. A friendly panel is not interesting. In fact, this is the 4th panel I have attended today. Everybody is nice to each other. So I'm going to start on a fighting,
That's what we are doing.
I'm going to you saying algorithm is only 20%, technology is only 20%. I heard the moderator say digital technology is a small piece of everything.
Of the puzzle.
It's like saying, oh, you have a Tesla. The battery is just a small component. The wheels are big, the car is big. You have seen the big truck, right? Ugly looking truck. The battery is very small. If the battery is not there, Tesla is not going anywhere. Right? So
That is true.
But if the wheels are not there, it's not going anywhere.
everything is important. But I won't badmouth wheels. Although I have designed the electric battery, I'm an electrical engineer. So that's all I want to say. The second point I want to make, when you say technology is a small component, there is a kind of a belief that it's a done deal. Let me tell you, it doesn't work that well as you all think it is, maybe. That's the problem. We face 2 questions. Does AI work everywhere? Does AI work for everyone?
And all the time.
AI work for everywhere is a question of data adaptation, domain generalization. AI built using data in US, it's not going to fly in India or any other country. And so that's one issue. That's what I've been doing for 20 years. Telling people domain adaptation, generalization is the most important issue. I did a lot of AI development. My first AI course was in 1978. Kim Nielsen's book. Somebody has read from that book? Yeah, you're at least 70 years old. So, since then, a lot of things have happened. Those days, AI was not doing well. We all did computer vision. And once we think, computer vision is the one that brought AI back. AlexNet?
Yeah.
People know that, 2012. Okay, so having said that, I also think the bias issue is also important in technology development. And some of the things that we still have to do in technology are working well in defense, because I do a lot of things for DARPA and DoD. a lot of things for IR. I've been very successful in translating big fixed systems to Department of Justice, Homeland Security, and DOD. You know why? We got tons of data. Okay? And I go to medicine. I went to Hopkins in 2020. Okay, I'm going to do this for medicine. AI for medicine, healthcare. I see two things. Small data with good annotations, tons of data with no annotations.
Yeah.
Hopkins collects data every day. We have a patient. Every patient we collect data. We collect EHR, diagnostic images, conversations between patient and the doctor. Nobody has time to annotate them. So if you are still in the supervised mode of learning, tough luck. You can't do anything. And then we do these things, movement-related disorders, endocrinology things, OCT for brain cancer, cataract, eye disease, 80 patients data with annotation. So you have to do the brain valve test. Okay, so what worked in defense and intelligence community for me is not working in medicine and AI because the data science component is not still solved yet. I have a thing to say. I need 1,001 AIs in medicine. What works for TB ain't working for diabetes. It's a different issue totally. Different data, different diagnosis, different domain knowledge. AI won by using data, it lost by dropping domain knowledge. In medicine, if you don't do domain knowledge, that means you don't need white coats. You do need white coats. So TB, whatever is done, has to be done in the consultation with the final doctor. Nobody is going to OR because deep learning said, please go to OR. That's not happening. Okay, so these are all the challenges. So the first fight I have, when you say technology is this much, it's like saying the person is 70 years old, but the first 5 years didn't really matter. No, it mattered. That's when everything happens. So, just trying to poke you a little bit. All right, okay, let me just stop here. And I have more things to pick on later.
Technology is important and the wheels are important and the driver is important. Not so much with Tesla. With Tesla, sure. Okay, so we'll keep on that theme. I had to stop this group of panelists in the meeting room because the debate got heated and we're just getting there. And I said, hold it for the audience. Don't burn out already. So okay, so moving on to thinking about we haven't solved for the technology. Okay, agree. And so maybe we want to take a step back, and I think this is like the piece that gets left out. It comes after the fact. Our regulations, our governance, our policy ecosystem is catching up with the technology often, and I'm thinking of more like lower resource country setting, right? So what do we need to do to make the technology work better? Also to have like better ownership, better as Dr. Chellappa said, like domain right focus. And I'm not going to the data focus yet, but maybe speak first, Marelize, to the regulatory governance environment that's needed for data and for the technology to work.
I mean, it's a big question, so I'm going to try and piece my answer in three pieces. I think, first of all, that it's really important to make a distinction between those things that we already know work and we just don't have the resources to scale them, right? When we talk about data, foundational to all of what we've spoken about today, but not yet mentioned, is the fact that data and devices are not affordable in many low and middle income countries, right? 2 gigabytes of data cost 11% of monthly GDP per capita in low income countries. That is more than the total monthly commuting cost of traveling from home to work and back, which is 9% of monthly GDP per capita. As long as it is more expensive to look on your phone at 15 minutes or 20 minutes of Facebook than to get to work every day, you are the potential of what we've spoken about today. The potential of all of what we've spoken about today is going to be available to younger populations and people living in urban areas in higher income brackets of the population. So that's the first point I want to make. Getting to, and the second point around the regulatory aspects, provided that, imagine we're in a society where everyone had access to free 2 gigabytes of data every month and a smartphone. We would be in a different society than what we are now. But imagine that universe is in place. I would say the second thing we need to think about when we think about regulation is we need to think about the difference between that which we already know works and we're just not scaling it versus the unknown unknowns. And AI is such a fast, I'm specifically thinking here about AI, that is such a fast moving space that I wouldn't want to predict in a year from now where we will be in AI medicine, because there is just a lot of unknowns. What we do need, and Shibu and I had this conversation before we walked up here, what we do need a lot more of are the health technology assessments, right? That really tells us what is the cost effectiveness of this technology compared to a laboratory test, compared to other things. Because if we don't have that in place, the regulatory piece is really difficult. And then I think the third thing is to do with data ownership, right? With understanding where the data are coming from, who has given consent for that data to be used, and therefore, how can we trust and validate the outputs that these tools generate? Keep in mind that last week, the FDA, for the very first time, the FDA here in the US, for the very first time, looked at and produced some guidance on the use of generative AI and the regulation of generative AI in medicine. It is unknown territory. When I buy a Tylenol here in the US, and I buy that same Tylenol in India, or I buy it in Nigeria, or I buy it in Niger, it should have the same active ingredients, theoretically. Not always, but for the most part, it should, right? I didn't go to a CVS on Monday and I buy Tylenol, and on Tuesday, the active ingredients are slightly different. But that's what happens with generative AI. So there's a lot that we know, but there's also even the significant regulatory authorities, the FDA, the European Medicines Agency, the MHRA, the Medicines Health Regulatory Authority in the UK. They have not yet figured out the generative AI part and regulation. The last thing I will say is, for those folks who are involved in developing solutions in the generative AI space when it comes to regulation, we know that what will be incredibly important is post-market surveillance. So after approval or clearance, I should say, has been granted, what does the regulation look like, and what does the ongoing surveillance look like on the other side of that clearance to make sure that these solutions always work. And the toughest one of all those points that I've made, probably for us to think about and conceptualize, is where are the data coming from, who the data belongs to, and how we think about consent in this space.
Thank you, Marelize. That was very comprehensive. I think one sort of piece I would add is that in all of this, there is also educating the users, which is just a huge part of regulation, right? Because there is the risk, and then there is the perception of risk. And to make this concrete, one specific example, and this is it follows the advances in LLMs and ChatGPT. Our team at Hopkins with IVAC was working on a non-generative conversational agent that was AI-based and natural language processing based that we worked together with on IBM. It was non-generative. It provided information about the COVID-19 vaccine. It was integrated with about 25 health departments across the country. But when ChatGPT and generative AI became sort of the headlines of every newspaper, the health departments became concerned, right? And we couldn't distinguish for them fast enough that actually the bot you have embedded in your health department is not generative. And the perception of risk was sufficient that they were like, we're not ready yet. And so I think that's maybe to add to your point. And then I think you're about to add to it, so I'll just turn over to you before to go.
My PhD thesis was on generative AI in 1981. But I could only generate 32 by 32 pictures because I had to share a PDP 1145 with 30 other PhD students at Purdue. Okay, so let me give you a story. Chennai, 30, 40 years, 50 years ago, this one fellow somehow got admitted into a general hospital in Chennai. For some reason, he was there for 6 months. He took copious notes. He went outside. He started his own dispensary, clinic. He was very successful. For a few years, he made money. This is a real story. You can check it out.
Yes.
And then he got some ideas. He said he was going to divorce his wife and marry a younger woman. She called the state and said, this is not a real doctor. He's a fake doctor. He learned whatever he did by being a patient in general hospital in Chennai for 6 months. Now, ChatGPT is slightly better version of that.
It's not real.
It's not 6 months. A lot of data.
Yeah.
So what he learned in one hospital in one ward, 6 months, he could start a very successful clinic. He gave shots, he gave medicine, headache, okay, take Calzone. That's the Indian medicine, like Tylenol those days, you know that, right? And things like
Not
that.
at all.
Yeah, anyway, all I'm saying is, now in terms of Tylenol being same, we had some time here, Tylenol had some extra ingredients that caused some anxiety for us. You may remember that. So LLM will hallucinate. Because, listen, if you have some new ideas that is outside the box, it's a hallucination.
Yeah.
It's just a good hallucination. So why we have to understand all generative models will create things that it has not seen with some probability, and we have to manage that. And this is where none of the AI technologies will directly go to prescribe something. It will be in consult with the doctor. Don't forget the white coats in AI. You know, AI is going to give some hypotheses. If you do X-rays, yeah, maybe, and then they go and take a look, right? And we can make it better with multimodal reasoning, right? You talked about other things that could be used. In addition to X-ray for improving. Multitask learning is what we are doing. Multimodal learning is, nobody does just single. We do HR, diagnostic images, converse. In fact, we have a paper recently that talks about what kind of biases LLMs can have, just like the clinical bias, confirmation bias, overconfidence bias, and so forth. Okay, and we are talking, I know, Shibu is a doctor. I have, my 2 kids are doctors. Anesthesiologist, internal medicine. My son-in-law is a doctor. My nephew is a neurologist. So I'm very careful. As Seinfeld says, everybody says their doctor is great. What about the doctors who got C's and D's in their classes? Do we complain about them? And LLM could be like that.
Yeah.
So, but we do have doctors like that who make mistakes. So when it comes to AI, suddenly we get all worked up. Oh my God, it does this. And there are doctors who make mistakes. As somebody famously said, what happens when a doctor makes a mistake? Gets buried, right? I'm sorry. I'm trying to be a little provocative here. So all I'm saying is, don't make AI bad. AI is a good thing. It's like a 2-year-old precocious child with excellent skills in calculus. Why do I say that? Stochastic gradient descent. How many of you use that in your back propagation? Chain rule, the partial differential calculus. Somehow this 2-year-old is brilliant in calculus, but it's a 2-year-old. It has lots of issues. So we have to be very careful. When we point out all the issues with AI, look at the people who designed the AI algorithm. When I design my AI algorithm, I know where it fails. I'm supposed to announce it to you. I'm supposed to tell you. When a medicine comes out, evening dinner I'm having, there is a medicine for something, Farxiga. Good. For something, and then it's bad for 10 other things. I have breathing problem, I have certain headache, I may faint, I may fall. All medicines have these side reactions, so AI will have that too. So don't badmouth AI. It's something I've grown up for 45 years. I feel very bad when AI does it. I said, no, we design AI. AI has not started designing itself. Okay, so,
Not yet.
yeah, right.
Yeah, and I mean, you're also saying that it should be used together with white coat but
That's why it's good that
here's
he
my
has.
fight. That a lot of care happens online, huh? So the average patient is spending 5 minutes with their white coat doctor and then 5 months online searching for a diagnosis. Dr. Google is I think the primary doctor. So there is I won't let you respond. Being shown 10 minutes time to the end here. And so the debate that I interrupted in the meeting room, I want to take us back to that. I can see some audience members sleeping. I think they need a wake-up call as well. This idea of data, which a few people here have sort of pointed to, yeah? And with data comes power, right? There is, I think you spoke about having sort of deep domain expertise where data needs to be contextualized to a disease, to a context. And what we're seeing, especially in the world of LLMs, all of the discussion on ambient scribing, right, where we're really solving for that issue of like, how do doctors or clinicians enter data into like an EHR or some kind of database, is that we are leveraging models that are, 3 or 4 companies, run by 3 or 4 companies. And in some ways, we're not regulating that space. Countries are, in some ways, giving away their data to these companies. And it is sort of a new era of digital colonialism if we don't sort of modulate it in the right way, where we're not essentially empowering or setting up systems that empower countries to own, customize, retain data. And of course, there is a complexity, which Marelize, maybe you'll point out, of like, how do we contextualize enough to like the smaller countries that don't have skills? But I would love to hear your reflections on that. Maybe, Marelize, I'll start with you, and then we'll ask our panelists to keep comments under 2 minutes.
This is an impossible ask in under 2 minutes. Let me just say that it is true on the one hand that we don't want data colonialism, right? Let me also say on the other hand that countries whose data are not included in models will be countries who will be less able to use the outputs of an LLM. Imagine we were designing a tourism app and there was no data for one particular country available in that tourism LLM because the country just didn't have any digital data available. You can have all the AI outputs, design perfect itineraries and flight schedules and hotels and everything else. And that country's cities and hotels will never be featured and will never get, so the country can't get benefit, right? So it's really about understanding the balance between risk and benefit. That will be my 2-minute comment on this.
Thank you. And Shibu, over to you, and then I'm sure we'll have some wise words from Dr. Chellappa at the end, please.
I think there comes the partnership and also trust. So if you wait for every country to have their innate or, contextualize the hype around nationalistic LLMs, we will be losing the race. So there comes the partnership and also the trust. So the collaborations, if we look at the history of even other technological revolutions, it started with partnership. I think the global bodies, for example, in tuberculosis, even the LLM thing, the global bodies like a STOP-TB partnership, the WHO started actually kind of creating that partnership, pushing countries to actually move data and share data. The common sharing platforms has been now facilitated by STOP-TB partnership. And government of India does a lot of things, within the country to have regional representation of data, especially starting with the imaging data. They started already oral cancer data set creation from multiple parts of, when they are now getting into the X-ray data creations. So similar, NIH used to actually do that. We trained our algorithm with NIH data first, and then we have to procure from multiple countries. I'm just saying, so starting the same principle, use the same principle of how we can actually make certain things open source and call out these are the caveats. So I think we can't solve everything. So we can at least say, okay, this is the margin of error. I think probably you are going to make it. And then this is the level of contextualization you need to actually do. So I'll give an example. Even in our existing algorithm, it's not an LLM thing. We do a calibration within every country. So we use the previous data sets of X-rays and we source it. And prior to implementation, we kind of calibrate to actually adjust to the local context, because it won't, within India also, it may work in Kerala, it won't work in Delhi. So there has to be calibration. So that there is a process already inbuilt, so we can actually kind of build onto that and then use the same principle for LLM also.
Yeah, and I think India also provides a very unique ground, right? Because India is owning its data, like the Bhashini program, and there are multiple government-led initiatives that are saying how can we source, retain, and contain multiple dialects, contextualize our data, like the data banks, but also like making it medical language specific. So over to you, Dr. Chellappa.
UK biobank data is very good. We use it for lots of our algorithms, enhanced data, lookalike data. So there are lots of these kinds of data. But in Hopkins, even within Hopkins, for me to get medical data into engineering space where I have all my GPUs, I have to make sure that IRB things are all followed and protection is there so people won't grab the data. So that's very important with the medical data. I think while data is important, what's also important is let's develop methods that are impactful for diseases that are more prevalent in India. Yeah. South Indians have a high propensity to have heart issues. It's a genetic issue. South Asians, Indians in particular, in Chennai and the places I know in Andhra and other places, carb intake is very high. So there's very large diabetes. Once you're 40, it will be very rare for a South Indian to not have diabetes. And so there are many things like that. So while data is also important, I would argue that Indian medicine AI should focus on Indian diseases that can be helped with AI, so you can see much. And there is something common between Indian population disease and Native American population diseases, high incidence of diabetes also in Native American population. And the equation I want you to think about is AI plus world health data is equal to healthy world. Put it on your t-shirt. I'm a mathematician, I put equations. Repeat after me. AI plus world health data is equal to healthy world. I think every government wants its citizens to be healthy. It cuts medical costs. Citizens will live longer, be productive, the country advances. So eventually they have to accept this equation, Chellappa equation. Then they'll be fine.
I want to go back to the very first point I made, which is we spoke earlier about a pregnant woman who happened to be HIV positive with TB and gestational diabetes, right? We are not going to get to the Chellappa equation of world health data if that pregnant woman's data is sitting in 4 siloed applications without a unique identifier, whether it is in a federated system or a shared health record, without all that data coming together. The AI will never learn about that woman's entire history and her future of her baby, genetic components, lifestyle components, and so on. So it is just so incredibly, if there's one message to me that we should take away from this entire discussion is if every government at national level, at state level, really needs to care about putting its health data in one place. It doesn't need to be in a physical one server, but connecting all the siloed health data dots, because we do in the health sector have a problem of many islands of small bits of data about parts of a person's health. Even here in the US, if you've lived in the US, you have filled out several patient portals, one for your dentist, one for your ophthalmologist, and there's different versions of you because not a single one of you in this room have filled out your entire medical history for your dentist and your ophthalmologist, and because what does my broken leg have to do with my ophthalmologist, right? So that's the point, right? Really, the need to really care about bringing all the health data about patients over their lifetime together has never been more urgent or important.
Thank you. Those are some excellent Gorgens equation. Gorgens. healthy competition here. I think I'm told that we have time for one or two audience questions. If there are any, yes, please come forward with your question. I like both the Chellappa and the Gorgens equations. I think we'll
I'm
have
sure
first.
Shibu has one too.
Shibu, do you have a Vijayan equation? Go
I had two questions. I have two questions, but I will, it's hard to choose. I'll just ask away. So having been on grounds and knowing in depth about data collection issues, what are some of your tips and do's and don'ts and recommendations about young business owners, researchers, about how to approach on-ground raw data? It looks like you're on the other side of where you have so much knowledge, and maybe we can learn from that. And yeah, I would love to know more about
That's a great question. Is there another question? Maybe we can take two questions before we, yes, please. Yes. Before we turn over to our panel.
So I'm in law school right now, and I kind of have an interest in digital health, so I don't know too much about it yet. But in your opinion, I guess maybe in the US, you can maybe even compare India if you want to. What things need to change in the legal world in terms of legal regulations to kind of facilitate more innovation in digital health and AI?
Fire the lawyers.
If you'd like to start first.
The first address, we don't come up with a new app. We already have an app store with the all the health workers. So that's the best. So when we started this, again from learning, we insisted to use the Qure platform. But again, that is an additional ask for this thing. So you're actually overburdening people. So try to, the best way to, because most of the countries, they won't allow to integrate an application with their existing application. It's an effort from their side and our side. So we have to go with what the country offers. So just start with the paying for any project funding. But if the country has a digitization roadmap similar to what India has, like now it is thinking in that line, but we are not reached there. A single ID to track all this is to cover all these things is a first step to do that. The simple unique ID. And that also is not linked to other. Now we are actually creating a duplicate ID for it. There are 4 other reasons, but again, you say less ideal, but again, that's a starting point. I think that should be the best possible scenario I can
Thank you. Yeah, and so the two sort of IDs in India are Aadhaar ID, if you don't have one, get it, and Aadhaar ID, and they are legally, to your point, separated. The law requires for a separate ID for health. Marelize, maybe, and then we'll turn over to our friend.
I was going to respond to the first question. I think the importance of unique identifier and knowing what the country's regulations are for collecting, storing, and safeguarding health data. I come across so many small businesses that have a cool app that runs on a local laptop with absolutely no protection whatsoever, right? So to the first question. To your second question about legal protection, we spend a lot of time in talking with governments about that. And the whole area of data protection and what that looks like and the level and kinds of data protection that are needed is contentious and difficult in many countries, but it's also still lacking in many low and middle income countries. If I recall, it took a while for India's data protection law to make its way through all the legislative processes in the country. And this is an area, even countries that have some form of existing data protection, the existing data protection laws don't often work well for health data because we want to walk this middle ground between neither under-regulating nor over-regulating access, right? We do want to be able to use some anonymized data for surveillance purposes, disease surveillance purposes, for example, right? And it's not possible to individually give consent in those situations. So that would be my answer to that question.
Thank you. Yeah, and for those who haven't seen India's data protection law, in my mind, it's like a beautiful sermon. It really brings together like our scriptures and our ethos in theory. In practice, it's not yet fully executed. Yeah. But I think the theory of it is actually quite beautiful.
I'll quickly run over 3 things that we have done with data. One is a Bill Gates funded project with Soumya Acharya, who couldn't be here personal issues to take care of. This is to identify mosquitoes. I don't like them. So we work with African countries to collect a lot of samples of mosquitoes so we can decide which are the bad ones, which are the, good, there are some good mosquitoes.
Morphological identity.
Yeah, and it's very hard, they all look alike, right? So, but anyway, I'm very interested in the project. As I said, I don't like mosquitoes. 66,000 people die every year because of these little guys. Now, USAID was supporting the African countries, Bill Gates was supporting ours. So now we have a problem, not how data should be collected, whether countries will have money to collect data that can help AI. That's one issue. The other positive issues, we have an NIH project with Arvind Hospital. My colleagues from Bloomberg Institute of Hopkins, we collect cell phone based data for eye cataract diseases, because in camps you collect data and we can give a decision right there and so forth. So that was working well, except that I got a note from NIH saying if you have any foreign collaborations and so on, that's going to be an issue and so forth. This has now come very recently. So I'm not sure how that's going to happen. The third most important issue is that if you don't have somebody in India working with you jointly to collect data, there will be distress that somehow I'm going to take their data and find a new therapy and run away with it. And what are they going to get from? Because data is gold right now. So you have to also take care of that. So things have become more complicated. USAID cancellation, and then the NIH initiative in terms of how foreign entities can be involved in the proposal, and the third one, lack of trust. There have been cases like that, rich countries going to some poor countries, collecting data, running away with that. There are examples of that. So those are the issues.
Okay, I think lots of wisdom, and I think we'll have time to continue talking to the panelists. So with that, we can wrap up. Thank you so much for everyone's time. Thank you for coming.
Thank you.
Yeah. Thank you, Smisha. Thank you so much. Thank you.
So we reconvene at the theater at 3:20 p.m. Currently, we break for a short break for refreshments, networking in the lobby. Soon after this panel, we'll also have a Seva exhibit walkthrough here in the same room. So if you're interested, you can stay back. But please enjoy the snacks and refreshments that we're offering in the lobby, and see you all at 3:20 p.m. in the theater. Thank you.
It was really nicely organized.